Hello and welcome back. This is Dr. Steve, your physical therapist, and today we are talking about common misconceptions and myths that I've seen far too long in my career and even before I was a PT through the really healthcare, physical activity. You could just chalk it up to just being things that we just look at face value and we don't really question, just kind of take them as truth. And when you start breaking them down, we actually see that they don't make a whole lot of sense. And so I want to do that for you today and start to spread a little bit more truth here on YouTube, kind of about the body, about how movement works, and just kind of what we're seeing in the science and evidence in the present. Please take a look at my disclaimers in the description. Please like and subscribe if you like this content and turn on those notifications for future videos. And please post any comments or questions that you have down in the video's comment section, and I'll get to them all, I promise. So let's jump right into this. This is from a presentation I did a few years ago, and I dug this up, and they're all here. I mean, this isn't comprehensive. These are just the big ones. These are the big ones that I could think of that I've heard so much in my career. And the first one, for good posture, do X, Y, Z, or ABC, or this or that. And it's one of those things that I think when you first look at this, the start of the sentence, good posture implies that there's good versus bad. And we know now, there's really no such thing as good posture or perfect posture. Really, what we're seeing come from the literature, what we're seeing come from the kind of the ergonomic side is that really your next posture is your best posture. And that just means try not to get stuck in one position for too long. That, I think is one of these things that we've done as a society is that we kind of have a collective unspoken agreement about what's good and what's bad, right? Is that's a, symmetrical, upright individual that looks good, and then we have this other individual that might look crooked or asymmetrical or sideways and leaning. That doesn't look good. And really, when it comes down to the sitting, standing, however you want to look at posture, I did a video on sitting not that long ago. Check that out. I really talk about the problem here is stillness and stagnation, right? And so that's why posture variation is king, and trying to move and trying to not get stuck in one position for too long is really how you can maintain good posture and really kind of reap the benefits of still being able to move and vary that posture and not get stuck in one position for too long, which we know physical inactivity has a lot more potential consequences than just posture itself. So this next one kind of refers to posture as well, but scapular retraction and depression causes shoulder impingement. These are big PT words. This is big kind of, anatomy lingo here. Let's talk about this. Scapular refers to the shoulder blades. Retraction and depression just refers to how those shoulder blades can move. So we talk about retraction, which is squeezing them together, bringing your shoulder blades and squeezing them together. Depression refers to pulling them down. So if you do that together, you kind of turn into, we kind of call it almost like a military type posture, right? Chest is high, shoulders are way back. Causes shoulder impingement. Impingement's a fancy word for just pinching or compression of some tendons in your shoulder. We know this isn't founded on anything. Again, it's just another thing that I've heard throughout my career that, if you get into this certain posture or positioning, that you're going to have some kind of problem. We know there's no causal relationship there. We just tend to say things like this. What I would tell somebody who was in this position and who was here, maybe give them some other positions and some other postures to get into, right? Vary it up. Try not to get stuck in one position for too long. And we know that necessarily doesn't cause or lead to anything impingement-wise or any kind of shoulder dysfunction-wise in that way. So this next one, we could spend the rest of the video talking about it, but lifting with your spine/back causes injury/damage. Now, I've heard this one. This is the one that I've heard probably the longest, and this dates back to even before I was a PT. and just growing up. And I think, again, it's just society and generationally, like, just passed down, is that, you hear people talking about, don't lift with your back, lift with your legs. And when you start breaking that down, it doesn't make a whole lot of sense, right? I've had patients of mine tell me, I know I have good lifting posture. Like, I have good lifting mechanics. I lift with my legs, not with my back. But they're in there seeing me for back pain. And you start deconstructing all of this, and you really, like, some common themes that I find here is that there's this sort of fear collectively in society around using our backs or using our spines. Back up a little bit. These areas that we're talking about, when you start talking about the low back is, it houses the biggest bones of the spinal column. It houses the biggest muscles that we have in our bodies, the biggest, most densest ligaments. When you start talking about how strong all of that is, it's really strong comparatively to any other body part that we have. And so I always challenge that notion, is that when you start talking about what is strong in the body and what is meant to be used, it's not meant to be protected and guarded. It's actually meant to be used as a human being, right? As a species, we're meant to be moving and meant to be used in those areas. So I find it troubling that people, have this fear of using this area because it's going to cause some kind of negative consequence. People are often surprised whenever they come in to see me with back issues. A lot of the times I have them start doing some back exercises, core, back, trunk type movements, and they start feeling better. These areas are meant to be used. Now, take that with a grain of salt. This is not a one-size-fits-all approach, cookie cutter type approach. People who have back pain, it's complicated, it's complex. Remember, pain is complex. If you saw my PT Talk series on pain, part 1, 2, and 3, pain is very complex. So we know that there's situations here where everybody's on a different timeline and timetable whenever we start prescribing and doing different things with movement and physical activity. So everybody's on a different wavelength. Everybody's got different comorbidities. Everybody's got different experiences, memories associated with pain, and everybody's got a different conditioning level. But what I'm getting at here is a common theme, is that I'm seeing if you're scared of using your back and you're fearful and protective and guarded, that's going to translate to the brain potentially being a little protective and guarded, and it's going to also translate to some deconditioning in that area. So weak cores require stabilization exercises. Another one where it's just like, what? And you might be sold on this whole stabilization idea. This is a PT term. I've seen it in personal training arena, and it's unfounded. And it's the requirement of certain exercises or a group of them doesn't make any sense when you start breaking this down. Weak cores respond well to any kind of exercise, any kind of movement, really. So, this idea that you have to do a certain kind or a certain, you lack stability, you might hear that, and then that could lead to instability at the spine, and that leads to a whole host of other issues. It's a fear-mongering, a scare tactic, and it doesn't actually make any sense when you break it down. People respond really well to stabilization exercises, and they respond well to other exercises too that aren't stabilization, that actually can strengthen their core. Before we move on, since this is so rooted in society, right? I mean, look at the things that are easily, like, some of the first search items that come back when I search the phrase in online. The next time you lift someone's spirits, lift with your legs, not your back. And so this is permeated through our society, and it's just a belief that we have. But again, it doesn't make a whole lot of sense when you break it down, right? So keep that in mind as we move on. This is another one that's just tough, and I've heard it a lot in my career, being a manual therapist that's using my hands, using manual techniques a lot on people, is that my sacrum is out. And they'll say other things: pelvis, SI joint, back, rib. Now, listen, if you've had a high impact, high trauma type force situation happen, and or you're hypermobile, there are possibilities where you've had some dislocations, and there is a possibility for a redislocation. But for the majority of the population, these terms are negative. They have negative consequences. They evoke a sense of fear again, and a sense of I'm not in control and I need to be dependent on someone to put me back together or put that joint back in. And it's just dangerous. It doesn't make a whole lot of sense when really, if we break it down, these areas of the body are not dislocating. They're not coming out. They're held together by the densest and, again, the strongest ligaments and muscles of the body. And what is happening is something completely different. And I have to educate people when they come to see me about this. It's a sometimes tense conversation because people's beliefs, a lot of them are strong and they've believed this stuff for a long time. But we need to start showing the evidence, and we need to start talking about this more, just like I want to in this video, that these situations are indeed not happening as much as we hear them and see them in clinic. Another example that comes to mind, I pulled this as well, is this whole leg length discrepancy thing. One leg is longer than the other. Super, super, super common. The other caveat that's common is people come in and they tell me, hey, one leg is longer than the other. I've been told that's what's happening, and that's why I'm having my back pain or my hip pain, my pelvic pain, my wherever they might be having pain. And again, the research is actually showing the opposite, and that this has no basis. Now, if your leg length discrepancy is significant, adding a heel lift can be tremendous, and addressing that leg length discrepancy can be huge and a benefit for you. But these small to medium range leg length discrepancies, I've seen them in people with symptoms and without symptoms. What does that tell you? A lot of the times we're stretching and we're actually just trying to reach for something here to make sense of it when it really doesn't make any sense. And it's actually quite normal, and it can be a common variant in the population, and really have no consequences associated with them. I don't want to exercise because I don't want to get bulky. Well, what people typically should just stop here at the sentence is I don't want to exercise, because what the science shows, and we know this, there's typical ways of training and eating to get bulky if you want to get bulky. And we can do that pretty easily given volume manipulation. That's changing the sets and the reps. It's training variation, periodizing, however you want to look at it, and the way you eat as well. So we know that a lot of the times this is just an excuse, and I have to call people out on this a lot of the times. It's not comfortable, but I'll do it because I really tell people exercise, physical activity is the lowest hanging fruit you have right now to actually help you in the situation that you're experiencing right now. So lo and behold, it's probably the best evidence we have for treating and managing a lot of the issues. And if we could get on this exercise train, not only would we be healthier as a society, right? But a lot of the pain and a lot of the problems that we see in the therapy world and the medical world would probably be, people would be better off. My pain is coming from my muscle knots. This is another tough one. This is really, really tough. This is a short way of explaining this, but can't you just rub my pain away? Can't tell you how many times I've heard that. My issue is that, when you look at the literature, muscle knots or trigger points, myofascial trigger points, they're all the same thing. A lot of people have them. I mean, we all have muscle knots. We all have hyper-excitable or hyper-irritable places potentially in the muscle that may be symptomatic or may not be symptomatic when you start touching them or pushing on them, some causing pain, some not. So they're ill-defined, right? We don't have a really good definition for them, and we don't have a really good sense of what they are in general. So if we don't really understand, I've said this before, if we don't understand what they are, how can we understand how to treat them effectively? And how effective is it if, time and time again, as a PT, I've talked to a lot of PTs, I've experienced this myself, and I've talked to a lot of massage therapists who are hands-on, that if you treat these muscle knots and you look at rubbing them, massaging them, doing soft tissue work, whatever it might be, it might help transiently, it might help short term, but these people typically are a revolving door, and they just return and return and return. So are you really addressing the foundation? Are you really addressing the root problem here? Typically not. So we have to get to the root. And this comes to the last point here. The cortisone shot made my pain go away. I've heard this time and time again as well. And this is also, it's short-sighted because Cortisone is a steroid. Steroid's an anti-inflammatory. If there's true inflammation in the area and the doc does the cortisone shot and targets the tissue and is able to actually target that properly and rid the inflammation, great. But what's causing the inflammation? And that's the question a lot of the times I pose to my clients and my patients is I kind of quiz them and go, well, did it really take it away? Indirectly, right? If we flood the area with an anti-inflammatory and it gets rid of the inflammation, great. But did that shot actually take care of what was causing the inflammation? No. So it's indirect in that sense. And what happens with these people? A large amount of these people don't have inflammation at all, and they get a cortisone shot and they say it made my pain go away. Well, that doesn't make any sense either. That's likely a placebo effect. And we could talk a lot about placebo and nocebo, and I plan to in future videos, but it's complex and it's complicated. And again, I think it's just an oversimplified way. A lot of these are just oversimplified ways for us to explain things we don't understand that we're just trying to piece together. When you start breaking them down logically, you go, wait a minute, that doesn't make a whole lot of sense. So I hope this was helpful. I hope this starts to shine some light. Maybe you've got some other examples that you could post in the comments below and I can address them. I would love to, and I'd love to expand on this topic in future videos. Thank you for being here. I really appreciate it. This is Dr. Steve, your physical therapist. We'll see you in the next video. Take care. Bye-bye.